We live in an era where, we have robots performing open heart surgery and lasers that can correct your vision in a matter of seconds.
Right. It's pretty incredible.
It is. But then, yet, if you were one of the millions of women who leak urine simply by, like, sneezing or laughing, modern medicine essentially offers you two extremes.
Yeah. And neither is great.
Exactly. You either do endless Kegels and just sort of hope for the best, or you let a surgeon implant a piece of synthetic plastic mesh into your pelvic floor.
Which carries a lot of baggage, to put it
A
lightly.
ton of baggage. Welcome to the deep dive. Today, we're looking at a condition that feels, I don't know, incredibly low tech, but affects nearly half of all women at some point in their lives. We're talking about stress urinary incontinence, or SUI.
And more importantly, we are exploring a potential treatment that sits right between those two extremes you mentioned.
Right. We're looking at whether autologous platelet-rich plasma, or PRP, which is, the serum spun from your own blood, can be injected into the vaginal wall to actually stimulate your body to repair the urethral sphincter.
We really have a substantial stack of clinical trials, systematic reviews, and medical literature to sift through today for this.
Yeah, we've got a lot of ground to cover.
Our mission is to look at the data behind this regenerative approach. Some people in the field are actually calling it liquid gold. We need to figure out if, taking blood from your arm to rebuild the tissue in your pelvic floor is a genuine medical breakthrough for SUI.
Or if it's just like promising hype that completely fails to hold up in clinical practice.
Exactly.
So I want to start by figuring out why this new treatment is even on the table in the first place. Because you'd think with a condition this common, we'd have a better grip on it by now.
You would think so, yeah.
To understand the proposed fix, we really have to understand the physical breakdown. When the sources define SUI as involuntary leakage due to effort, exertion, or, increased abdominal pressure, we're talking about basic mechanics.
Super mechanics, yes.
A sneeze, a cough, lifting a heavy box. These actions create this sudden, really intense downward pressure in the abdomen. If things are working normally, your body handles it. But when someone has SUI, what is structurally failing in that exact moment?
Well, the failure happens in the architecture of the pelvic floor itself, and it's far more complex than just a single muscle failing.
Right, it's a whole system.
Exactly. The literature describes it as a highly integrated musculofascial and ligament destruction.
That is a mouthful.
It is. But basically, you have the levator antemuscle group, the endopelvic fascia, and the urethral sphincter complex. Together, they act as the dynamic support system for all your pelvic organs.
Okay.
They're responsible for providing the countertension needed to keep the urethra clamped shut when that abdominal pressure spikes from, say, a sneeze.
Reading through the anatomical descriptions in our sources, it really struck me how much this resembles like a suspension bridge.
Oh, that's a really good way to look at it.
Yeah, because the ligaments are acting as the cables.
Yeah.
Right, holding the tension. And the muscle groups are the concrete foundation. As long as the cables are taut and the foundation is solid, the bridge can handle a massive sudden load.
Like a truck driving over it.
Exactly. Or, in our case, a violent sneeze. But the literature outlines some major life events that basically act as, well, earthquakes to this bridge.
Right, and childbirth is the most immediate physical stressor there.
Sure.
Pushing a baby through the birth canal can mechanically stretch, tear, and literally permanently alter those supporting structures. The cables just get overstretched.
They lose that elasticity.
Exactly. Then you have to factor in aging and estrogen deficiency, particularly during menopause. Estrogen plays a massive role in maintaining the elasticity and thickness of connective tissue.
Wow, so when estrogen drops,
When it drops, we see a progressive long-term degradation of the collagen that actually makes up those ligaments and fascia.
so the cables are stretched, the concrete is crumbling, and the bridge is just sagging.
That's the reality of it, yeah.
The sources refer to the end result of this as intrinsic sphincter deficiency, or ISD. The sphincter simply cannot maintain the pressure transmission needed to stay closed against the downward force of a cosh.
Right.
Now, traditionally, if a physical bridge is sagging, engineers bring in skeel supports. And reading through the standard medical solutions, that seems to be exactly what surgeons have been doing.
It's a very structural approach.
Yeah, procedures like colposuspension, bulking agents, and most commonly, mid-urethral slings. They basically go in and place a synthetic mesh hammock under the urethra to physically prop it back up.
And from a purely mechanical standpoint, the mid-urethral sling became the gold standard because it does prop the bridge back up effectively.
So that's the leak.
It stops the leaking for a vast majority of patients. But the mechanical solution introduces a completely new biological problem.
And this is where I found myself really pushing back against the current standard of care while I was reviewing these clinical trials. The sources note that mid-urethral slings carry up to a 6% complication rate.
Which is significant.
It really is.
Yeah.
I mean, on paper, 6% might not sound like a huge number to a statistician, but when you are treating millions of women, that translates to a staggering number of people experiencing severe life-altering issues.
Absolutely.
What is the body actually doing to this synthetic mesh to cause such catastrophic failures?
Well, the body is basically reacting to a foreign object.
Hmm.
You're placing rigid synthetic plastic into a highly dynamic, very sensitive and muscular area that is meant to stretch and move with the body.
Right.
So for that 6%, the body's immune system attacks the mesh. This leads to chronic inflammation and rigid scar tissue formation.
Wow.
The literature details complications like severe chronic pelvic pain and voiding dysfunction, meaning the mesh is so tight the patient has difficulty actually emptying their bladder.
That sounds awful.
We also see high rates of dyspareunia, which is painful intercourse.
And the most terrifying complication I saw mentioned was vaginal mesh erosion.
Yes. Erosion occurs when the synthetic material essentially saws its way through the surrounding tissue over time.
Well, it literally saws through the tissue.
It does. It eventually exposes the mesh right through the vaginal wall. It is incredibly painful. It can lead to chronic infections, and it often requires complex, invasive surgeries to attempt to extract the mesh.
Which by that point is probably just completely entangled with the patient's own scar tissue, right?
Exactly. It's a nightmare to remove.
That sounds barbaric.
People-
I mean, we are trying to fix a sagging bridge by just jamming rigid steel beams underneath it, which eventually rust and tear right through the remaining concrete.
It's definitely not a natural fix.
No, not at all. And this realization seems to be the exact pivot point that led researchers to look at platelet-rich plasma. Because instead of relying on a synthetic scaffold to artificially prop up failing tissue, scientists started asking, well, is there a way to actually rebuild the original tissue?
Shifting from structural compensation to true biological regeneration.
Let's explore how this regenerative process actually works, because on its face, it sounds a little bit like science fiction.
It kind of does.
PRP stands for platelet-rich plasma. The sources defined it as an autologous blood-derived concentrate. Autologous, meaning it is sourced directly from your own body.
Right.
You go into a clinic, they draw a standard vial of your blood, and they spin it down in a centrifuge using specific FDA-approved kits. This separates the red blood cells, leaving you with plasma packed with a massive concentration of platelets.
And historically, the medical field thought platelets were essentially just the body's patching material.
Like they just clump together to stop you from bleeding when you got a cut.
Exactly. But the real breakthrough in this specific field goes back to 1974, when researchers Kohler and Lipton discovered that platelets are actually powerful growth stimulants.
Oh, wow.
Yeah, they don't just stop bleeding, they initiate the entire wound healing cascade.
So looking at the literature detailing what happens when this concentrated plasma is injected into the anterior vaginal wall and the periurethral area, the focus isn't really on the fluid itself.
No, not at all.
It's on the bioactive molecules released by the platelets once they're activated in the tissue.
Oh.
I kept seeing these specific growth factors mentioned over and over: PDGF, TGF-beta, and VEGF.
Yes, those are the big three.
If my reading is correct, these are basically the chemical signals that trick the localized tissue into thinking it has sustained a major injury, which prompts it to start rebuilding.
That's a great way to summarize it. Think of those growth factors as the chemical messengers that tell your body's dormant cells to, wake up and get to work.
Okay.
So PDGF, which is platelet-derived growth factor, and TGF-beta, transforming growth factor beta, they're primarily responsible for the recruitment and proliferation of fibroblasts.
And fibroblasts are what again?
Fibroblasts are the specialized cells in your body that synthesize collagen. So by flooding the weakened endopelvic fascia with these signals, you're literally commanding the body to actively lay down dense, new connective tissue.
That is amazing. And then there's VEGF, right? Vascular endothelial growth factor.
Correct.
The sources indicate this one stimulates angiogenesis, so it's prompting the formation of brand new blood vessels, making sure this new collagen matrix has the oxygen and nutrients it needs to actually survive.
Exactly. And there is even evidence suggesting this cascade stimulates myogenesis, which is the actual generation of new muscle cells in the urethral sphincter.
It's a profound shift in how we treat tissue degradation. To bring it back to our earlier metaphor, PRP isn't the scaffolding itself.
Right.
It's the chemical signal calling in the materials. It uses VEGF to build new blood vessel supply lines and TGF-beta to synthesize the actual collagen structure. You're turning the body's own innate healing mechanisms up to an 11 and pointing them exactly where the structural integrity has failed.
The theory is incredibly elegant, but of course a biological blueprint is only useful if it actually translates to clinical results.
Exactly. We have to look at whether this targeted construction crew actually stops the leaking in a real human body.
Let's look at the actual clinical protocols.
Yeah. Based on the literature, a patient doesn't just, walk in for one shot and walk out cured.
No, it's a process. The typical protocol outlined in the studies involves taking about 5 to 6 milliliters of this concentrated PRP and injecting it meticulously into the periurethral area and the anterior vaginal wall.
Okay.
And because tissue regeneration takes time, this is generally repeated once a month for about 3 to 4 consecutive months. You're layering the biological signals to ensure continuous collagen and muscle synthesis.
Which brings us to the results. Do we have proof that this layering works?
We do have some compelling data.
The systematic reviews heavily reference a 2021 prospective pilot study by Athanasiou and colleagues. This study is fascinating because they took women who were already booked and waiting on the surgical list for an SUI operation, and they offered them this PRP protocol instead.
It's a bold study design.
Yeah. And to measure if it worked, they used a very objective physical metric.
Yeah.
The 1-hour pad test.
Right. The 1-hour pad test is crucial because it removes the subjectivity of a patient simply saying they, feel better.
Right. It's hard data.
The patient wears a pre-weighed pad, drinks a specific amount of water, and then undergoes a standardized series of physical exercises, coughing, jumping, bending, for exactly 1 hour.
Just really putting the system under stress.
Exactly. Then the pad is weighed again to measure the exact gram amount of urine that leaked.
So in this study, before receiving the PRP treatment, these women had an average leakage of 15 grams on the pad test.
Right.
Let's contextualize that for a second. 15 grams is roughly a tablespoon of fluid. Imagine a tablespoon of liquid suddenly escaping every time you cough or try to go for a jog.
Significant.
That necessitates wearing heavy incontinence pads constantly. It dictates what clothes you wear, how far you travel from a bathroom, and whether you participate in physical activities at all.
It completely alters your lifestyle.
But after the 3 to 4 month PRP protocol, that leakage dropped significantly, down to an average of just 6.2 grams.
And a reduction from 15 grams to 6.2 grams fundamentally alters a patient's daily reality.
I bet.
It can be the difference between constantly worrying about an embarrassing visible leak ruining your clothes and, merely needing a thin preventative panty liner during a heavy workout.
Wow.
The patients in these early studies also reported massive improvements on standardized quality of life questionnaires. They just felt more confident and their physical boundaries really expanded.
The pilot data paints a very optimistic picture. But we have to look at the entire stack of sources, and this is where I need to play devil's advocate for a minute.
Go for it.
Because as transformative as a drop from 15 grams to 6.2 grams sounds, we have a 2021 randomized clinical trial by Dinesh Baju and colleagues that ran a head-to-head comparison.
Yes, the RCT.
Right? They took one group of women and gave them the PRP injections, and took another group and gave them the traditional mid-urethral surgical sling. And the data is undeniable. The surgical sling resulted in a significantly higher mean improvement in symptom scores compared to the PRP group.
The surgical sling was objectively more effective at completely halting the leaks and bringing those specific symptom scores closer to 0 over the timeline of the study.
So I am looking at this trial, and if the invasive surgery just flat out works better to stop the leaks, why are we even dedicating an entire deep dive to PRP?
It's a fair question.
I mean, if my pelvic floor is essentially collapsing, I don't care how elegant the biological blueprint is. I want the steel beam that works today. Why would any listener dealing with SUI knowingly choose a less effective treatment option?
And that reaction gets to the very core of how we define success in modern medicine.
What do you mean?
You're looking purely at raw efficacy, the ability to completely stop the leak. But a patient evaluating treatment options has to look at the risk-to-reward ratio. We have to bring the conversation back to that 6% complication rate for the surgical mesh.
Ah, right, the chronic pain.
Exactly. A surgical sling might give you a higher statistical probability of being perfectly dry, but to get that dryness, you are literally rolling the dice on chronic, debilitating pelvic pain, painful sex, or needing further surgeries to physically cut eroded mesh out of your vaginal wall.
So a cure isn't really a cure if it replaces your incontinence with severe chronic pain.
For a significant portion of the population, absolute dryness just isn't worth the risk of a catastrophic complication. PRP offers a different path.
It's about compromise.
Right. It appeals to patients looking for moderate, clinically meaningful improvement, like cutting their leakage by more than half without taking on the risk of permanent, life-altering surgical complications.
That makes total sense.
Medical success isn't always about achieving a perfect score on a symptom sheet. Often, it's about offering choices that align with a patient's individual risk tolerance and their lifestyle goals.
Okay, so if we are prioritizing the avoidance of catastrophic risks, we really need to look closely at what risks PRP actually carries. Because, you are still getting multiple injections into a highly sensitive area of the body.
Yeah.
Let's talk about the safety profile and where the science actually stands today, kind of stripping away the marketing hype of liquid gold.
Well, the safety profile is undeniably PRP's strongest clinical asset. Because it's autologous, meaning made entirely from your own blood, the risk of immune rejection is zero.
Is zero.
Zero. Your body will never attack its own plasma as a foreign substance in the way it attacks synthetic mesh, and there is absolutely no risk of disease transmission from a donor.
But there still have to be some localized side effects from the procedure itself, right? I mean, needles are involved.
Yeah, sure. The clinical sources document localized side effects, but they're remarkably mild and transient. Following the injections, patients have reported an urgent need to urinate, a feeling of vaginal fullness, minor spotting, or just mild pressure and pinching during the injection itself.
That sounds pretty manageable.
It is, and the data consistently shows that all of these effects typically fade completely in under 3 weeks.
And since clinics generally use topical numbing agents before the injections, the physical discomfort is kept to a minimum. But are there any strict medical reasons why someone should avoid this procedure entirely?
Yes, the contraindications are very straightforward.
Okay,
PRP relies heavily on platelets and the body's natural clotting mechanisms, so it shouldn't be used by anyone with a severe coagulation or bleeding disorder.
that makes sense.
It's also contraindicated for patients with active cancer, as, introducing concentrated growth factors into a system battling malignancy is highly unadvisable.
Definitely.
And finally, it should not be performed on women who are pregnant.
Okay, let's get to the ultimate reality check. If a listener is sitting here right now, managing SUI every single day, and they are weighing their options,
Right.
we know Kegels often aren't enough for structural damage, and we know surgery is highly effective but potentially devastating. Should they view PRP as a proven, ready-to-go cure?
Well, if we look at the systematic reviews, those are the rigorous papers that analyze all the other available studies. Combined, the current scientific consensus states that the level of evidence for PRP in treating SUI is still considered low.
Wait, how does an approach with such positive pilot data and zero rejection risk end up with a low evidence rating?
It comes down to the methodology of the studies we currently have.
Okay.
While the initial results are incredibly promising, the sample sizes are small. Many of the early trials lack a true placebo control group, which makes it difficult to rule out the placebo effect entirely.
Sure.
But the biggest issue highlighted in the literature is the severe lack of standardization in how the PRP is actually prepared.
Meaning, like, different clinics are using different equipment to spin the blood.
Yes, and that variability actually changes the medicine itself. Platelets are delicate structures.
Okay.
If Clinic A uses a centrifuge that spins at a very high G-force, they might actually fracture the platelets before they even get into the syringe, prematurely dumping the growth factors and rendering the injection pretty much useless.
Oh, wow. I didn't think about that.
And if Clinic B uses a slow spin, they might leave too many red blood cells in the plasma, diluting the overall effect. So when one study concludes PRP is highly effective and another study concludes PRP showed minimal results, they might literally be evaluating completely different biological yields.
That explains why the sources heavily emphasize the need for large-scale standardized trials like the recent Ashton et al. 2024 trial.
Exactly.
They're trying to lock in the exact centrifuge speeds, the precise concentration yields, and the optimal injection protocols so that a patient in New York gets the exact same biological therapy as a patient in London.
Which is how medicine should work.
Right. So until that standardization happens across the board, It sounds like PRP should be viewed as a highly promising, low-risk experimental bridge rather than a definitively proven universal cure.
That is exactly the most accurate way to frame it based on current medical literature. It's an evolving therapy with massive potential, but it is still in the process of being fully optimized.
To bring this all together for you listening, autologous PRP injections into the anterior vaginal wall represent a profound paradigm shift in how we approach stress urinary incontinence.
They really do.
By taking your own blood, concentrating the platelets, and injecting them directly into the damaged pelvic floor, you are essentially calling in a biological construction crew. You're leveraging your own VEGF and TGF-beta to build new collagen, form new blood vessels, and potentially generate new muscle where the tissue is degraded.
And while the head-to-head clinical trials demonstrate that it may not yet definitively beat synthetic mid-urethral slings and raw absolute efficacy for stopping leaks, it completely bypasses the severe, sometimes devastating complications associated with synthetic meshes. It offers a low-risk option for significant life-improving symptom reduction.
We are moving away from treating the body like a broken machine that just needs a piece of synthetic hardware bolted into it, and moving toward treating the body as a living ecosystem that simply needs the right concentrated chemical signals to heal itself.
And as the clinical trials become more robust and the preparation protocols become standardized, regenerative approaches like this could very well become the new standard of care, drastically reducing our reliance on synthetic implants.
Which leaves me with one final thought, something for you to ponder long after this deep dive ends. If we're successfully learning how to extract, concentrate, and deploy our own blood to rebuild degraded structures like the urethral sphincter, well, if we're effectively learning how to turn our own bodies into a pharmacy, what else is on the horizon?
It's a huge question.
Think about the other age-related structural breakdowns we all inevitably face. Things that currently require synthetic meshes, or joint replacements, or invasive titanium scaffolds. What other failing parts of our bodies might soon be cured, not by a surgeon's scalpel or piece of plastic, but simply by a targeted shot of our own biology?
It really changes the whole landscape.
It makes you look at that vial of blood at your annual physical a little differently, doesn't it? The answers to our structural breakdowns aren't just in the broken parts. The blueprints for the repairs are in the blood flowing right past them. Thank you for joining us on this deep dive. Keep asking questions, keep exploring, and we will catch you next time.